The Art of Medicine, episode number 30, April 4th, 2021. Repairing, Licensing, and Credentialing, a discussion with Dr. Donnie Bell. Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm Dr. Andrew Wilner, and my guest today is Dr. Donnie Bell. Welcome, Dr. Bell.
Thanks, Dr. Wilner. Thank you for having me.
Dr. Bell, I invited you on the program because you were co-author of a journal article that spoke to one of my kind of favorite topics, which is medical licensing and credentialing and the waste therein. So first, tell me a little bit about yourself, how you came to write the article, and then tell us what you wrote.
Thank you, Dr. Wilner. I'm Donnie Bell, Deputy Chief Medical Officer at New York City Health and Hospitals. I'm a practicing neuro-interventional radiologist, and I also serve as the Deputy Chief Medical Officer. And part of our roles and responsibilities is to oversee the medical staff and credentialing of our practitioners.
Great. So that's why I asked you to be on the program. Is credentialing and licensing is something that I ran into as a locum tenens physician, which I practiced for many years. I started in 1982. And since then, off and on, I've been doing locums. I wrote a book on it. And, I wrote a chapter on the pros and cons. And probably the biggest con about doing locums, the hardest thing is that every time you get a new position in a new state, you got to get a new state license. And even if you're well established, and this has just happened to me recently where I'm working here in Memphis, Tennessee at the county hospital, and our teaching program also includes the Veterans Hospital, literally across the street. It took me 2 years, not joking here, I'm not exaggerating. I think it was 23 months to get privileges so that I could start working across the street. And I'll mention that I don't have anything in my background, no drug dealing, no felonies, haven't had my license. I have actually, up till now, a perfect, pristine record. And even so, the process can be so cumbersome that when you start telling the stories, you get riled up and, you think it's like a Saturday Night Live routine. Oh, I sent the thing in and then they lost it. And then I did it again. And then I had to get my fingerprints done, 3 times. And, it just goes on and on. It's like, how can this be? So you wrote an article about this. You were co-author in one of the JAMA, Journal of the American Medical Association. And I saw that. I said, oh, I got to talk to this guy. So what did you say in your article?
So unfortunately, Andrew, your experience is way too common. And even pre-pandemic, from our own providers, as well as going through the credentialing process myself, we noticed that there was a lot of room to improve the efficiency of the process, to say the least. And again, the examples you just gave are very frequent in terms of the proximity of facilities that our providers were trying to gain credentialing and privileging to could be literally right across the street and still require a number of redundant and inefficient processes in order to provide care and give access to our patients. So that was the backdrop of our work in trying to improve our credentialing processes pre-pandemic, and then COVID-19 hit. And initially, our concerns were that we would need additional PPE, which we did, that we would need additional ventilators, which we did to a certain extent. But the most valuable resource that we found and the most difficult to procure was people. And part of the reason that was difficult was because of all of the licensure and credentialing processes that are required in order to safely onboard clinicians, be they physicians, nurses, respiratory therapists, physical therapists, what have you. Now, fortunately, there are sort of emergency or disaster um, mechanisms that we utilize in order to meet the demand of onboarding hundreds, if not thousands, of providers very, very quickly to take care of very, very critically ill patients, which included the state government allowing practitioners with other state licenses to practice in the state of New York, as well as a healthcare system, us utilizing our disaster credentialing and privileging processes. But even with those mechanisms, it was still very challenging to onboard very quickly a number of providers, and it brought in greater relief the difficulties with credentialing and licensure pre-pandemic.
So I just want to step back for a minute. And I don't have any problem with physicians and other healthcare providers undergoing a credentialing process and a licensing process. Of course, we need to make sure that everybody's background is what they say it is, and literally they're not convicted felons, or, or if they have, they've served their time and they're back at work, but that process, the way it's done now, has to be reproduced in every state and reproduced at every facility. And it's not just a complaint of convenience. There are patients waiting to be treated, which became sort of acute in COVID. And there are physicians and other healthcare providers waiting to jump in, and they can't. So people are literally suffering because of the bureaucracy. And on the other hand, from the doctor's point of view, for example, I'm working now in Memphis in a full-time position, in part because it was very, very difficult to continue locums, always getting new credentialing, because they want to review everything you've ever done. And, and the older you get, the more your CV gets longer. And so it became a big process. So it took 9 months to get my Tennessee medical license. And so I started 3 months later than our agreed upon date because I did not have my license. So there were 3 months where I could not work. Now, patients could not be taken care of, but I did not have an income for 3 months because I was supposed to be working. Now, luckily, I was able to rely on some of my other licenses, and scramble around. But I mean, there's a real threat to physicians being able to move to a new facility, which is kind of part of life these days, and I think part of the problem is, go back 50 years, doctors got one license, stayed in one spot, right? Practiced there for 40 years and then retired and we're done. So the need for multiple licenses wasn't that great, or the need to multiple geographies weren't that mobile. And then, of course, I don't want to skip telemedicine. I practice as a telemedicine physician, and the way the law is written is you must have a license in your state and the state where the patient is, wherever that is. So if you're going to be a telemedicine doc all over the country, you need 50 licenses. And there are docs I know who have 30 state licenses, which is the bureaucracy involved and the cost and so on. So what did you propose to fix this problem?
So I think there are two components to that. The first is the licensure component. And so, there are pros and cons to having a nationalized medical license. And so one of the major pros speaks to what you just described, enabling providers to practice in multiple states, which is increasingly becoming more common due to telemedicine, as you just described. And again, telemedicine was becoming more prevalent before COVID, and COVID only rapidly accelerated its adoption to levels that we'd never seen before. So certainly that's a need for the future and going forward. um, and a major pro. A con might be how do we then regulate the practice of medicine? And I think that's what the states are concerned about. If there needs to be disciplinary action and there's only a federal or national level regulatory agency, then that might slow the process down. So I think our suggestion uh, would be to expand on an institution that already exists, which is the Interstate Medical License Compact. And by doing so, you sort of get the best of both worlds, right? You ease the process by which physicians and other practitioners can obtain licenses in other states, while also maintaining the state regulatory authority for the licenses. So I think that's sort of the best of both worlds and a practically feasible approach to try to address the licensure issue.
So I'm just going to, for those who are unfamiliar, because I've explored this IMLC, what they do is they say for states who are members, and I think it's around 27 states now, they will accept a certain amount of your documents as having been verified by state A, so that when you apply to state B, they'll say, oh, state A already checked all these, those are okay. So you only have to do sort of parts 2, 3, 4, and 5 and pay us and keep up your CME to get your state license. So it doesn't provide a common license, and it's not reciprocity, but it allows for some common acceptance of documentation that they vet a good part of your application. So I agree. I think it's a step. I've become a fan of the federal license, and I'm going to ask you, I'll ask you now. So what happened in COVID was the state said, okay, we need you. We'll just waive that requirement for now. You want to work in New York, you're licensed in Pennsylvania, just go for it. And because the con of the argument is, well, what about, the states overseeing all the care and all the disciplinary action and all the problems? It's going to be easier to fix on a local level. That's the argument. So we've been doing it now for 6 months plus. What's the fallout?
Well, I think the jury's still out there, Andrew. So I think we're going to have to wait and see there.
Okay, so we don't have enough information because I haven't read anything to say that, oh, there's been a lot of malpractice and patients aren't getting, what they need, and doctors, are practicing outside their scope. I haven't seen one headline to suggest that the local state licensing is really necessary.
And to that point, and to piggyback there, and we mentioned this in our paper, the VA. They essentially have a national license. If you're licensed in a state, you can practice within the VA health system throughout the country. And so that could be another source for us to turn to see how regulatory issues are handled. But I think there is some precedent for a national license to some degree, whether it's through a compact or within an umbrella organization such as the VA. I think we're starting to see that it can work, and there may be regulatory issues that we have to iron out down the road, and maybe that will be another teaching point from COVID. In this is, what is sort of the legal fallout from implementing this sort of essentially national license, and hopefully we can learn quickly from that and use the challenges of COVID as an opportunity to modernize both the licensure and the credentialing processes.
Right. So credentialing has that been relaxed also? Or how has that been dealt with?
Yeah, so at New York City Health and Hospitals, we leverage what's known as disaster privileges. And so they're a more streamlined version of the credentialing / privileging process to get a provider safely into a hospital. Even with that, right, because licensure and credentialing, the processes themselves, in addition to being redundant, as you described, oftentimes are also outdated. They rely on outdated technologies such as siloed databases or faxes or emails. And so because of that, that process that further slows and delays the process. So I think those are going to be things that we'll be looking to modernize and change in addition going forward.
Well, I'm going to go on record and say that not only do I think there should be a national medical license, I think there should be an international medical license. I do some medical volunteer work in the Philippines. Cannot legally practice medicine in the Philippines. So I have to have a special certificate that says they're waiving it because I'm a volunteer and so on. And of course, all of Europe has all of its own rules, and medicine's pretty unique. We're all dealing with human beings that, despite some very trivial outward appearances on the inside, are all pretty much the same. And so there is a lot of logic to allowing physicians who are trained to sort of practice, wherever they happen to be and wherever the patients happen to be. Now, from a practical point of view, how is this going to get done? I think the states are kind of stubborn. They don't want to give up their kind of ownership of the state medical board and what they do. And of course, they get a lot of funding from, medical license costs $500 a year. I calculated once there are 1 million physicians in the US, plus or minus. So at $500 a year for their licenses, it's an average, some are less, some are more. We're talking about $500 million, $500 million in licensing. You want to cut medical costs? Hey, $500 million. You could cut that by, I'm not sure about the percentage, but if you divide by 50, right, and just had one, be a lot less, right? Mm-hmm. So that would be one way to go. Even if you had to grow the staff of the federal one, sounds like a simple way to go. So you mentioned in your article an repository that there ought to be, a giant file with all of Dr. Wilner's, diplomas and residency, certificates and any sanctions or whatever, so that anybody who wants to license me can just log in there and get it without each time. How do we make this happen? The states kind of seem to have all the power. We're just sitting here, at our desks. Is there some organization that's going to help us kind of achieve this worthwhile goal?
Right. So I think, as we mentioned in the paper, I think the federal government is probably best positioned to accelerate the change here. Each provider has to get a national practitioner identifier. I think that could be a great anchor for this sort of database. And I think, that's
which already exists. That already exists.
Right. So I think that's where the real driver has to start. And they're also a payer. So I think when you couple all of that, that's a great place to start.
Well, this has been pretty interesting, Donnie. Tell me, is there anything else that our viewers should know or I should know about this medical licensing? Of course, everybody wants to know. So when COVID finally phases out, what's going to happen to these disaster plans? Are we just going to go back? What about your institution? You just going to go back to the way it was? Or are you going to make some changes?
Yeah, that's typically how it works. Once your organization is outside of a declared emergency, then you can't leverage the disaster processes, and you go back to your standard operating procedure. So I think the silver lining here is that we have an opportunity with COVID in healthcare, as with many other industries, where a significant problem has been highlighted. And now we have technologies today that didn't exist, 5, 10, 20 years ago, that can help us address those inefficiencies and those challenges. in new ways. And I think COVID has enabled us to accelerate change in a way that we might not have otherwise been able to. And hopefully that that holds true for the licensure and credentialing process as well, both in terms of how it's structured, um, in terms of being more of a national process for both licensure and credentialing, if that's via compacts or the like, in addition to making changes to the data infrastructure that it sits on. So I hope that COVID accelerates those things, and that we don't fully go back to the prior operating procedures.
Dr. Bell, I want to thank you for joining us on The Art of Medicine. I've really enjoyed talking to you about one of my favorite topics that hopefully next time we talk about it will be improved. We're certainly going to, well, you've heard my input, and whenever I have an opportunity, I'm pushing for it, and I know you are too. So thank you very much for appearing on the program.
Absolutely, and thank you for having me.
Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. Disclaimer: while this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. Hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com